The following podcast is part of a certified educational activity titled New Standards for CLL Care with BTK Inhibitors Using Evidence to Make Personalized Treatment Choices. Access the entire activity and complete the post-test at peerview.com/SYN860. Downloadable slides and practice aids are also available.
Hello, my name is Bill Werda from the MD Anderson Cancer Center, and welcome to our ASCO symposium today with peer review entitled New Standards of CLL Care with BTK Inhibitors Using Evidence to Make Personalized Treatment Choices. I'm joined today by my co-panelists, Dr. Nicole Lamanna and Carrie Rogers. Thank you to Medical Learning Institute and PVI, Peer View Institute for Medical Education, for providing this session, and AstraZeneca for providing the educational grant for this symposium. I'm going to start off with an introductory section and just give a high-level view of BTK inhibitors and their use in chronic lymphocytic leukemia. Sort of a historical perspective. It was about a little bit more than 10 years ago that we first started the clinical development of inhibitors of BTK, reflecting on some of the basic biology of the CLL and CLL cells. You can see these cartoons here of surface proteins that are expressed, particularly on CLL cells. Starting on the far left, you can see a cartoon of the B-cell receptor that is expressed in CLL. That's a monoclonal protein that each of the cells express, that is the B-cell receptor, and the associated downstream signaling molecules you can see on the internal side of the cell, for example, BTK, PI3 kinase, etc. That signaling pathway is somewhat intact, and those cells can participate in signaling, and particularly the downstream molecules. And that's important because what we've learned through development of these small molecule inhibitors is that if you block that signaling, for example, through inhibition of BTK, you can shut down the signaling that is occurring in the CLL cells, and as a result, the CLL cells will undergo apoptosis and die, and therefore these small molecule inhibitors of these signaling proteins have been demonstrated as therapeutically active in treating the disease. Now, the first inhibitor of Bruton's tyrosine kinase that was developed and has been approved is ibrutinib. There are others. Ibrutinib was the first in class. It's an oral agent. It's administered once daily. And it does inhibit not only BTK, but it has other kinases that it inhibits that we'll talk about in a minute that may relate to some of the toxicities that we see associated with BTK and this class of drugs. Subsequent drugs have been developed, such as acalabrutinib, which acalabrutinib has been referred to as a second-generation BTK, with the intent of inhibiting BTK, but also making the drugs more selective and narrowing this inhibition of off-target kinases, and thereby potentially reducing the side effect and toxicity profile that we see with these drugs. As I mentioned, ibrutinib is approved for CLL. Acalabrutinib also broadly approved for CLL, and we'll be talking extensively in this discussion about both of those agents. Zanubrutinib is not yet approved for CLL, but we do expect it to be approved in the near future. It is currently approved for mantle cell. And those three drugs are examples of covalent inhibitors of BTK, where they covalently bind to BTK, and this is how they function to inhibit the kinase activity. Newer drugs, as we'll talk about, are in development that are irreversible inhibitors. They don't require the cysteine 481 moiety for binding and inhibition. Pirtobrutinib is one such reversible inhibitor, which is in clinical development, and we will hear more about that during this session as well. As I mentioned, ibrutinib has been around the longest. We have the most experience with ibrutinib. There are numerous clinical trials that have been done with ibrutinib with long-term follow-up. This is irreversible inhibition of BTK through covalent binding to the cysteine 481 amino acid of BTK. And in cells where the protein has been bound by ibrutinib, the only way to regain BTK is to produce new BTK in that cell with these irreversible inhibitors. They're very active, they're very well tolerated. They do require continuous treatment, and we'll have a discussion about the relevance of that. And as I mentioned, there are other kinases that are inhibited, and those are shown at the bottom of the slide here. And that potentially relates to the side effect profile that we see. An example of two such kinases that are inhibited by ibrutinib are shown here. TEC, which may relate to the increased risk for bleeding, as well as EGFR, which may relate to the rash and other side effects that are seen with ibrutinib and other irreversible inhibitors of BTK. Now, this is a kinome for not just ibrutinib, but other of the irreversible inhibitors of BTK, acalabrutinib to the left. BTK on this kinome is located in about the 10 o'clock position. So you can see that they all inhibit BTK, but those other small red dots are other kinases that are inhibited. And so you can see, for example, ibrutinib, there are a number of other kinases that are inhibited, while when we look at the second generation compounds like acalabrutinib to the left, you see fewer red dots and fewer off-target kinases that are inhibited by that compound. Now, these agents are clearly have been studied in phase 3 clinical trials and are approved broadly in CLL, particularly ibrutinib and acalabrutinib. We will be hearing about others of the irreversible inhibitors. This is the NCCN recommendation for preferred regimens for frontline treatment. And you can see those are listed as category 1, acalabrutinib, ibrutinib, both for the fit younger patients at the bottom as well as the more frail patients at the top. We have another treatment option in the frontline setting that is a category 1, and that's venetoclax. We will be talking also about venetoclax in this session. And then these are the options for relapsed disease, and as you can see, the BTK inhibitors also appear in this list of options for relapsed disease, as well as venetoclax and the PI3 kinase inhibitors, duvelisib and idelalisib, which we'll hear a little bit about. I mentioned and spoke a lot about the irreversible inhibitors, but there are a number of reversible inhibitors under investigation. The furthest along is the LOXO 305 or pirtobrutinib. And this slide summarizes at the top a cartoon of the BTK molecule, and you can see in the small print at the very top the cysteine 481 and the location of cysteine 481 where the irreversible inhibitors bind to, while the reversible inhibitors will not require that cysteine 481. They potentially will have activity in patients who have mutation in cysteine 481 and will bind to other locations in the kinase or associated domain, and in that way will inhibit the kinase activity. So today's sessions will walk through treatments for treatment-naive patients with CLL, which I'll be discussing. We will discuss safety and side effect profile and toxicities, and treatment selection with regard to BTKs in the next session, and then sequential use of BTK inhibitors in CLL in our final session. So let's move on to the frontline discussion, and we'll talk about a couple cases, and I'd like to call in my colleagues when we go through these cases, just to highlight what the aspects of these cases are that are clinically relevant and important in terms of selection of first-line therapy. So our first case is a 75-year-old gentleman. As you know, most of these patients who have CLL who are needing treatment are older. They do sometimes have comorbidities that have to factor into our treatment choice. This particular patient had hypertension and diabetes and had a prior diagnosis of CLL, and over time has developed symptomatic disease with progressive anemia and hemoglobin of 10.4, and the associated symptoms being shortness of breath and dyspnea on exertion. By virtue of having a hemoglobin of 10.4, they're a Rise stage 3 disease, putting them in a higher risk category. FISH, at the time of treatment initiation, it was checked, and this patient has an 11q deletion. NGS sequencing revealed a wild-type TP53 and a mutated Notch1, and this patient has an unmutated IGHV gene. And as you probably know, most of the patients who have 11q deletion, about 95% of them will have an unmutated IGHV gene. Those patients being in somewhat a higher risk category, at least for time to first treatment. And we'll talk about the implications of these risk features in terms of their treatment and their first-line treatment. So perhaps we'll start with Carrie, and maybe you can give your perspective on some of the salient features for this particular patient in terms of selecting first-line therapy. And maybe just I'll highlight first that the two treatment sort of directions or roads or pathways that we can take for this patient are BTK inhibitor-based therapy versus BCL2 inhibitor-based therapy, as we saw from the first-line treatment options from the NCCN guidelines. So Carrie, can you just summarize some of the features that you think are important for this particular patient in selecting first-line therapy?
Yes, absolutely. I think one of the important things to think about is that we don't expect a difference in efficacy between these options of a continuous BTK inhibitor or a fixed-duration venetoclax-obinutuzumab. So this is where you can take into account other patient health conditions and patient preferences, because I don't see any features in this case that would lead me to believe one or the other would be more effective, and this person has been exposed to neither class of drugs previously. I do think that, while patients can have a preference for a fixed duration treatment, the number of visits required to do obinutuzumab and then start venetoclax with the tumor lysis risk mitigation strategy is a lot. And I do have patients that prefer to just add a pill to their medications every day and not do the kind of process involved with doing obinutuzumab and venetoclax. And so kind of on the patient preference side, the preference for a fixed duration with more upfront visits versus a continuous therapy with fewer visits, really people can have strong feelings about that. And then in terms of patient comorbidities, I do think, this person is a bit older and has hypertension. So if they are looking to take the BTK inhibitor, I would recommend acalabrutinib just because the rates of hypertension are less. And so in an older patient with hypertension, I think that, with diabetes and hypertension, this person's probably already on medications. Acalabrutinib's twice daily instead of ibrutinib, which is daily. And I think with the existing hypertension, acalabrutinib would be a better choice if a BTK inhibitor therapy is preferred.
I think both of you would agree with the statement that COVID has significantly impacted on how we manage our patients, how we think about patient care, and maybe one of you can comment on COVID and how that might factor into choice of treatment for this particular patient.
Yeah, I'm happy to comment. I mean, being in New York, but everywhere we got hit pretty hard, and you all did as well. Clearly, during people who needed therapy when things were very active with COVID, many of us decided to continue sort of choosing more BTKI therapy for the ease of administration and the decrease of frequency of hospitalizations or visits to the center, as well as the concern possibly of knowing that if they were getting an antibody therapy, how that would mitigate or impact vaccinations, but certainly COVID at the time for getting an infusion and more exposures to the center. So most of us, here in New York sort of favored more BTKI therapy along that route to minimize, obviously exposure.
Great. I think we touched on all of the important features for this particular patient. So we'll move on to the next patient. The next patient is a younger patient, a 64-year-old male with no significant comorbidities or other illnesses, presents with symptomatic CLL after watch and wait. Indication for treatment, again, is progressive anemia, thrombocytopenia. You can see hemoglobin of 9.4, platelets of 85. Patient is fatigue and has bruising, most likely related to the relative thrombocytopenia with a platelet count of 85. FISH shows 17p deletion and 13q deletion, which obviously has been trumped by the presence of 17p deletion, putting them in a high-risk category. And I would just remind people that this is a relatively uncommon occurrence. 17p occurs in about 5 to 8% of previously untreated patients who've been enrolled on our clinical trial. So it's not a common scenario, but it does occur, and I think it's important to have a discussion about it, particularly these days, because it does factor into how we think about treatment for these patients. NGS shows mutation in TP53, and as you probably all know, many or most, the majority of patients with 17p also have a mutation in TP53, and in this particular individual, they have a mutated IGHV gene. So symptomatic disease, needs treatment, progressive cytopenias, probably reflects extensive bone marrow involvement and progressive deterioration in blood counts. And this patient clearly has indications for treatment with high-risk features, 17p deletion and mutated TP53, which trump the more favorable features that this patient has, also, which you can see there as 13q deletion and a mutated immunoglobulin gene. So maybe we'll start with Nicole this time, and maybe you can highlight for us, for this particular patient, the things that are driving your decision and your recommendation for first-line therapy.
Yeah, as I alluded to earlier, because this patient is a high-risk patient, I would prefer giving continuous BTKI therapy. It doesn't mean that, obviously, I think the patient would respond very well to venetoclax and obinutuzumab, but we just have longer-term data from our ibrutinib, longer-term follow-up in ibrutinib in high-risk individuals. And so I'm still yet uncomfortable until we have longer follow-up on CLL14 with sort of stopping our higher risk individuals from continuous therapy to fixed duration. I would just like to see longer-term data on that. So I would prefer a BTK inhibitor in this patient because of their high-risk features.
Carrie?
I will add that I completely agree with everything Nicole just said. Although if you have someone that really shouldn't get a BTK inhibitor due to poorly controlled atrial arrhythmias that are leading to hospitalization, or use of warfarin, it is not at all inappropriate to give venetoclax and obinutuzumab, but my strong preference is for people without a contraindication with these high-risk features definitely to give the BTK inhibitor as long as it's not unreasonably toxic. Yeah. I also just want to point out that being mutated, IGHV mutated with 17p is uncommon and usually a bit better than unmutated and 17p. And I think people need to be careful because when you see a younger fit patient who's IGHV mutated, you might think, oh, this person could get FCR and get that benefit from FCR. But if you have a TP53 disruption or 17p deletion, that doesn't apply, and these patients should not be getting chemoimmunotherapy at all. So you just cross the option for chemoimmunotherapy off the list, even if you see that they're mutated.
Absolutely agreed.
Great. All right. I think probably the other thing that we should perhaps emphasize, I think most patients or many patients are being tested by FISH for presence of 17p deletion. That is a very important test to be done when deciding on first treatment, but also when selecting subsequent treatments for patients, because you can have patients who don't have 17p deletion initially and can acquire it over time. The other equally important thing to test for is mutation status in TP53. because we do see patients who don't have a 17p deletion, but do have mutated TP53. And we do also consider those patients high risk, and we approach them differently than we would if they didn't have a mutated TP53 potentially. For example, if we had a frontline, if this patient didn't have 17p deletion, but did have mutated TP53 and has a mutated IGHV gene, as Carrie points out, I would also not select chemoimmunotherapy-based treatment for this patient like FCR because of the presence of a mutated TP53, even in the absence of a 17p deletion. So both of those tests are important, 17p deletion and mutation status for TP53. Great discussion. I'm going to walk through some data now in terms of first-line therapy and highlight some of the key data elements that support the discussion that we just had and our selection for treatments. These, as I mentioned, are the critical features to test for when we're starting a patient on treatment. We need to know if the patient has 17p deletion. That's a test done by FISH, whether they have a mutated TP53, and also what their IGH mutation status is. The last feature, the mutation status of the immunoglobulin gene, doesn't change. As I mentioned previously, 17p and TP53 can change with time, and we need to retest for those if we're making a treatment change. This slide summarizes several of the first-line treatments, most of which are done with BTK inhibitor-based therapy. Those are the first 5, and then CLL14, which is at the bottom. Again, the substantive data right now that we have numerous trials with ibrutinib-based therapy. The Elevate-TN is a trial that we'll review briefly, was done with acalabrutinib, a second-generation irreversible inhibitor. And then CLL14 was done as a randomized trial with venetoclax-based therapy. The trials at the top, Resonate-2 and E1912, have demonstrated improvement in overall survival. I think that is an important feature. And I think we have seen improvement in survival for our patients with CLL in general with our targeted therapy, which has been very, very gratifying over recent years, for me to see at least. This slide summarizes Resonate-2 data. I think it's important because it sets some expectations with first-line BTK inhibitor or ibrutinib-based monotherapy. That's the gold curve, and you can see patients doing extremely well with a follow-up of about 5 years here. And so 70% of patients are progression-free, it looks like, at the 5-year end of that curve. So these patients do extremely well. We don't have a median PFS right now for first-line ibrutinib-based therapy with a very long follow-up. These drugs, particularly ibrutinib, in this case with Resonate-2, work in patients who were formerly thought as high risk, having high-risk disease. 11q on the left and IGHV mutation status on the right. You can see patients with 11q deletion do very well in terms of progression-free survival on continuous ibrutinib, as do patients with an unmutated immunoglobulin gene shown on right. So those don't appear to be high-risk features once patients go on BTK inhibitor-based first-line therapy. This is data that was presented here at ASCO, which is a follow-up to the Elevate-TN trial. This is progression-free survival that extends out beyond the initial presentation that was made by Dr. Sharman. This is a 3-arm trial of acalabrutinib monotherapy, acalabrutinib plus obinutuzumab. Those are the curves at the top. The monotherapy is the green curve, and the combination therapy is the purple curve, and you can see these patients doing extremely well in first-line therapy with continuous acalabrutinib-based treatment, and perhaps those patients who receive obinutuzumab in addition to acalabrutinib are doing better. Now, we do have data with ibrutinib plus rituximab. We don't think that rituximab adds to the activity of ibrutinib-based therapy. I think these data and this follow-up bring back a discussion about perhaps there is some importance to at least obinutuzumab in the frontline setting with BTK inhibitor-based therapy. But this is an area that continues to be somewhat debated. Acalabrutinib also working in high-risk patients. You can see this is the longer-term follow-up with acalabrutinib plus obinutuzumab among patients with 17p deletion or mutated TP53. At the top, those patients doing extremely well. The NCI group has published also long-term follow-up data with patients treated with ibrutinib who have 17p deletion or mutated TP53. These patients are categorized by their IGHV mutation status, and I think Carrie alluded to the fact that perhaps mutation status also can segregate patients who have a 17p deletion, and those patients having an unmutated V gene having a higher risk among those patients treated with BTK inhibitor-based therapy, as you can see in the red curve, both on the left for progression-free survival and on the right for overall survival. But exceptionally good outcomes with continuous BTK inhibitor-based therapy for patients with 17p deletion or mutated TP53. There is a prognostic model now that we have for BTK inhibitor-based therapy that includes both first-line and relapsed disease. These are the 4 factors that factor into this model. So I think these are important to pay attention to. 17p deletion, mutated TP53 status is important here. Also, beta-2 microglobulin and LDH appear to be important in this modeling, and you can see these curves and how patients segregate out based on the number of factors that they have, both for progression-free survival and overall survival. Now, this is a longer-term follow-up for BCL2 inhibitor-based therapy. This is the frontline venetoclax obinutuzumab versus chlorambucil obinutuzumab with very good progression-free survival seen with venetoclax-based therapy, which is a fixed duration treatment, as illustrated in the blue curve. And we do see responses among those patients with high-risk features. So on the left, you can see progression-free survival for unmutated cases in the blue curve, and on the right, in the dashed curves, you can see outcomes for patients with disruption in TP53. Now, this is fixed duration treatment. It's a bit different approach, and I think longer-term follow-up, while these patients do get very good remissions, even among those who have the high-risk features, I think really what we'll be telling is the long-term progression-free survival among those patients in the unmaintained state, particularly for those patients who have a mutated TP53 or 17p deletion. In terms of the newer work that's being done and where I think we're going with this approach and with treatments in general for patients with chronic lymphocytic leukemia, I think that lies with targeted therapy, and we're doing more and more work with combinations of targeted therapy. Now, the rationale for combined trials that have been done with BTK inhibitor plus BCL2 inhibitor-based treatment are the rationale is summarized here. They do have clinically complementary activity where the BTK inhibitors work extremely well in patients with nodal disease. They're less effective at clearing marrow and blood disease, while BCL2 inhibitor-based therapy is very effective at clearing disease in blood and bone marrow. And there has been preclinical data that supports synergy between the combination. We did a trial at MD Anderson with ibrutinib plus venetoclax, 3 months of ibrutinib monotherapy followed by 24 cycles of combined therapy. These are the undetectable MRD rates in bone marrow during treatment. As you can see in the green bars is the undetectable MRD rate. And about 75% of the patients at best response are undetectable in bone marrow with this combination. And that's better than we were ever able to achieve with our chemoimmunotherapy combinations of treatment. Progression-free survival and overall survival, while relatively short for first-line therapies, are very good, as illustrated in this slide, and activity and durable responses among patients who are high risk by IGHV mutation status on left and TP53 status on the right. The Captivate study was a large multi-center international trial that looked at this combination with a fixed duration of treatment of 12 cycles of combined therapy, where at the end of that 12 cycles of combined therapy, patients were randomized based on their confirmed MRD rate or MRD status. Those who were confirmed undetectable were randomized to placebo or ibrutinib, and this data was recently presented, and we now have a 2-year disease-free survival follow-up. And the bottom line here is that there was no difference in 1-year disease-free survival and now 2-year disease-free survival for those patients who are randomized to placebo versus ibrutinib. And this supports the concept of fixed duration treatment in the frontline setting, achieving an undetectable MRD status with the expectation that there will be durable remissions and disease-free survival associated with that response. And this slide summarizes a number of the phase 3 trials that are currently ongoing or have recently completed enrollment, and we're getting follow-up. In blue, I've highlighted combination targeted therapy arms that are being evaluated in these studies. So I'm very excited to see the next several years. It's going to take several years, but I'm excited to see the data that's going to emerge in terms of these targeted therapies. I think we'll see where we're eliminating chemoimmunotherapy, and we'll see what happens with the combined targeted therapy and how we achieve a best response and hopefully work towards cure for these patients. These are my take-home thoughts for this first-line section. BTK inhibitor-based therapy is extremely effective treatment. It does require continuous administration, and as we'll hear a little bit more about, does have associated side effects and toxicities. Those side effects and toxicities associated with a particular individual agents may be distinguishing features among the covalent BTK inhibitors. There doesn't seem to be any remarkable difference in efficacy, although again, these are all continuous treatment. Combination targeted therapies, I think, are the future, and we will be hearing more about those in the phase 3 trials. And I'm anxious and excited to see our progress and work towards curative therapies. And I'm very gratified to see that while 17P patients or patients who have mutated TP53 remain in a high-risk category, even among those treated with this targeted therapies, we do have effective treatments and active treatments for that high-risk group of patients, and their survival has improved remarkably compared to when we only had chemoimmunotherapy available. So great discussion. Next, I'd like to introduce my friend and colleague, Nicole Lamanna from Columbia University Medical Center and New York Presbyterian Hospital in New York City, and she's going to be discussing safety first with BTK options in CLL. Nicole?
Thanks, Bill. So obviously, Bill covered treatment-naive data, and I'm going to shift the focus a little bit and talk about safety with the different BTK therapies and what influences our decision-making when deciding between BTK and other, or even amongst the different BTKs. And later, obviously, Kerry is going to talk a little bit about sequencing. So let's start off with a case that we can discuss. So John is a 72-year-old gentleman who was diagnosed with CLL in 2014 and now requires therapy due to progressive cytopenias and bulky adenopathy. As always, we're going to talk about comorbidities of our patients, and certainly he has renal insufficiency with a creatinine of 2.1. He does have hypertension and is on medication for that. And his blood work includes a white blood cell count of 160,000, a hemoglobin of 9.5, and platelets of 95,000. He has a mutated IgHV with a normal karyotype. He has a deletion 13q, and he has no TP53 mutation by NGS. So now when discussing comorbidities, I'm going to pull in my colleagues here. What would you decide when you're thinking about whether continuous BTK therapy versus maybe fixed duration with obinutuzumab in this situation? Bill, you want to make a comment?
Sure. So I think for me, for this patient, the striking features and the things that factor in, and it's a little bit difficult situation because this is a type of patient that I would like to get in remission because he has features that would be associated with a long remission duration. not having a high-risk cytogenetic abnormality, and having a mutated immunoglobulin gene. That said, it's going to be harder to do with the agents that we have. The best agent to do that with targeted therapy would be venetoclax-based therapy, but the problem for this patient is that he has a high creatinine. His creatinine is 2.1. He has renal insufficiency. That puts him at even higher risk for tumor lysis syndrome, as does a high white count of 160,000. So his elevated creatinine makes me reluctant to recommend venetoclax-based therapy, although we can get patients through treatment, but it requires a little bit more work and more vigilance in terms of monitoring, et cetera. Also, the complicating factor is that the white count is high, and with whatever treatment he gets, so if he were to get venetoclax-based treatment, he would get obinutuzumab first, and with a creatinine of 2.1, and the potency of obinutuzumab and a white count of 160,000, he is at high risk for tumor lysis in that setting. So given that feature, probably what I would recommend more strongly for this patient, but I would have a discussion about treatment options and strategies, I would probably be inclined to recommend BTK inhibitor-based therapy for this patient at this point, to clear the disease and to get things stabilized, and perhaps reserve BCL2-based inhibitor sometime later down the road. So those are the things that I'm thinking about with this particular individual.
Carrie, any comments?
I completely agree with what Bill said. I think those are the major considerations. And when I've needed to, I have had patients at high risk for tumor lysis syndrome with impaired renal function that I've successfully gotten onto venetoclax, but I also work in a really resource-rich environment where we can do these things, and we're set to monitor for tumor lysis and handle that at a major cancer center, which is not always the reality in all practice settings. And I think the safety of BTK inhibitors here is going to be better. So unless there's a driving need to put someone through the additional hassle and risk of the tumor lysis syndrome, possibility of development and risk mitigation, the BTK inhibitor has a better kind of safety profile for this individual patient.
Great.
The one comment also I would add is sometimes we see renal insufficiency related to disease infiltration in the kidney. If you get them on effective treatment and can treat that, then the creatinine can improve with time.
Absolutely. That is a very well, a little bit of a rare complication, but certainly absolutely does occur, and absolutely would result in improvement of the creatinine if due to disease itself. But likely this patient would require hospitalization for monitoring to ensure safety due to the tumor lysis. And then I'm going to go on to the next case because it's the same patient, but I thought I would add when we talk about then the BTKs and lead into safety. So you have the same patient who's got renal insufficiency and a high white count, but he also has a history of factor V Leiden, and he's on, has a history of DVT, and he's on Coumadin. So now when you're talking about BTK options, maybe I would have my colleagues comment about, differentiation among the BTK inhibitors. Would they prefer one over another? Carrie, you want to start for this one?
Yes. So due to bleeding risk, warfarin was excluded from the major clinical trials with both ibrutinib and acalabrutinib, which are two approved agents. So unless there is some very unusual need to do this, I don't combine warfarin with these agents. However, there's nothing in this case. There are some direct oral anticoagulants that I've used with both BTK inhibitors. There's not good comparative data between warfarin and direct oral anticoagulants like apixaban or rivaroxaban, but I have done that. I don't believe this renal insufficiency is enough to exclude that class of drugs, so I would have a conversation with the patient about switching to a direct oral anticoagulant. If this was an unprovoked clot, they might, and it was more than 6 months ago, they might even be a candidate for the reduced dose apixaban or rivaroxaban, which would further reduce bleeding risk for the combination, especially if it's not a cancer-related thrombosis. I think that would be an option, but that certainly increases the risk of the BTK inhibitor with regards to bleeding complications. I generally favor acalabrutinib in people who are on anticoagulation due to experience with this, but I'm I'm not sure there's large-scale data at this point to really support that bleeding is significantly less with that agent.
Bill, you have any additional comments for
No,
this?
I would agree completely. So for this patient, I would be promoting the concept of BTK inhibitor-based therapy, switching to an alternative oral agent. All of the trials with the BTK inhibitors excluded warfarin, so we don't have data with safety, for example, with acalabrutinib plus warfarin. So we switch them if we're going to put them on a BTK inhibitor to an alternative oral agent. And I would agree with Carrie's comment in terms of not really having the objective data in the head-to-head comparisons about differences in bleeding risks between the irreversible inhibitors.
Okay, so that's a great discussion and a perfect lead-in. So we're going to talk about the comorbidities that help inform our choices in the frontline setting for our patients, which we consider for any therapy, whether BTK or other, of course. And then are the adverse events, what do we expect with BTK inhibitor therapy? What are the most common adverse events? Do they change over time with some of them? And what are the potential differences, as Bill just alluded to? We'll touch upon some of the head-to-head data that's emerging, and are there differences potentially in the safety profiles that may help inform our decision making? And so for the common toxicities of BTK inhibitors, these are well known to many of you. We talk a lot about the cardiac arrhythmias, atrial fibrillation, bleeding risks that we just talked about with anticoagulation that we mentioned in the case before, hypertension, arthralgias, infection, and GI side effects such as diarrhea. And then, of course, there are other known toxicities that are more plaguing sometimes to some of our patients. We have dermatologic changes. We can see rashes, both from a petechial bleeding type rashes to even nodular rashes, dermatologic brittle nails and thinning of hair, fatigue, which can be a little bit more difficult depending upon when that occurs, whether that's due to disease, drug, or other, and other arrhythmias besides atrial fibrillation, ventricular arrhythmias, and then cytopenias that can also occur. And then, of course, as Bill talked about earlier in his discussion, part of this may be based on some of these adverse events that we see with the BTK class may be different among the different agents due to, obviously, kinase selectivity. And certainly the head-to-head data will potentially see if there are differences depending upon that selectivity. And so when we talk about the off-target effects of the second-generation BTKs, potentially will they have less, given that kinome that we saw previously, will they have less off-target effects with TEC, EGFR, or ITK, which we presume are related, obviously, to some of these side effects that we're seeing with the BTKs. Now, clearly in clinical trial data, there tend to be the adverse events are different than what tend to be reported in the real world data. Now, obviously, real world data is retrospective, so we take that for what that is. But certainly, on clinical trials, obviously, patients are selected and have self-select themselves to be a part of clinical trials and might be a different group of patients and are followed more closely. So the adverse events sometimes are not as high as what we see once we start using these agents in commonality in real world. And so there have been many large experiences that have looked at patients on BTK inhibitors as well as PI3 kinase inhibitors, and there seems to be a higher discontinuation rate on the novel agents versus, let's say, progressive disease. So many patients may come off due to adverse events in the real world more commonly than we see in some of the clinical trial arena. And most of this happens to occur predominantly in the beginning of starting therapy in that first year. Part of this is being explored as to why that might occur. And so one of the publications that was noted is that certainly, remember, CLL is a disease of older patients. And certainly many of our patients have these comorbidities, and that's why when we talk about comorbidities and safeties, it helps us decide what might be a better agent for our patient depending upon the patient who's sitting in front of us. And so certainly patients who have more comorbidities, there was a higher discontinuation rate of ibrutinib therapy than noted in patients who obviously were more fit, and I think that makes intuitive sense. Because we have the most experience with ibrutinib, we have lots of data about the adverse events as we've learned and the longest follow-up. And so here are obviously some of the more key trials with ibrutinib-based therapy. And you can see different reports across all these different trials, from Resonate to Illuminate to the upfront studies with Alliance and the ECOG. And certainly you can see that atrial fibrillation seems to be higher in the Alliance, although these were any grade. We have in the teens compared to some of the earlier studies, which were single digits. And in the ECOG study, grade 3 or higher was 6.5%. There's hematologic toxicity. Now that included anemia, neutropenia, and thrombocytopenia. And certainly in the Alliance study and the ECOG study, the upfront, there was more grade 3 or higher of the cytopenias that were noted. Bleeding and hemorrhage, we see a lot of petechiae and bruising. Grade 3 or higher is not as common with the ibrutinib, and so the far fewer in terms of higher grade bleeding or hemorrhage, serious bleeding or hemorrhage. But you could see hypertension and infection, and grade 3 and higher infection. And infection is something we always deal with our CLL patients, but certainly with BTK inhibitors, I think that it should be noted that certainly we will see grade 3 or higher infection rates anywhere from 10 to 20%, depending upon the study. For acalabrutinib and zanubrutinib, we hear just some of the studies, and again, it appears that from some of these studies there might be a little bit less in the frequency of some of these adverse events. For arthralgias, mostly they were grade 1 and 2. Serious were very low. AFib, any grade lower in frequency, less than 5%. Hematologic toxicity still there, and grade 3 and higher. Bleeding and hemorrhage, again, not so much in serious, mostly any grade, anywhere from 15 to 20%. Infection still around 10 to 20%, grade 3 or higher. Hypertension seems to be less with acalabrutinib and zanubrutinib. But again, these are obviously not comparative data, and we have to look to the comparative data to be more helpful in that regard. Now, over time, there are differences in the adverse events that can occur with BTK inhibitors. And since, again, I'm highlighting ibrutinib because we have the most data on ibrutinib, there are some adverse events that tend to be early on and abate over time, and there are some adverse events that will be persistent. And I think the ones we talk about consistently tend to be hypertension. So that is something that does not seem to go away necessarily with time. So no matter how long somebody has been on ibrutinib, that's certainly something that can increase over time and need to be paid attention to. I think the infection risk still needs to be paid attention to. Hopefully, if the patients, those who are on longer term ibrutinib therapy, if their immune system improves as their response improves, maybe we'll see less infections. But you can see here that that's still there even 5 years out. Cytopenias seem to be earlier on and improve over time. Atrial fibrillation, I think, going along with hypertension certainly doesn't necessarily go away either. And certainly that's why I think many of us would argue that you need to control the hypertension that can occur on ibrutinib therapy, so that we mitigate some of those factors. But some of the GI and skin rashes and things are more earlier on and absolutely abate over time. Here, now that we're having longer follow-up on acalabrutinib, we also have some of that data as well, because now we have many years of acalabrutinib being around on clinical trial data. And again, highlighting that some of these side effects do abate after, early or over time. In fact, they're seen early, less than the first year, and then improve. So diarrhea, as I said, the bleeding or bruising petechiae then tend to be earlier on and get better over time. Headache is unique to acalabrutinib, so there certainly is, this is one side effect that is a little bit different than ibrutinib, but again, is something that occurs in the first few months and tends to absolutely get better over time and usually responds to supportive therapy. Upper respiratory infections, I think, are still, as I said, the infection risk, I think, is still persistent. And you could see hypertension, I think, certainly is something that still pervades the BTKI therapies and doesn't necessarily decrease over time, even with this agent, although there might be a decreased frequency with this drug. And so I think, AFib, certainly it isn't on this slide, so we put it up top for you to see that certainly the atrial fibrillation, all grades, was lower in frequency with acalabrutinib versus what we saw previously on some of the ibrutinib studies, but we're looking forward to the head-to-head data. Zanubrutinib is obviously the newer BTK inhibitor. for second generation, and we have less long-term follow-up. But you can see similar, in terms of the class, similar side effect profiles with all the BTK inhibitors. Decreased atrial fibrillation similar to acalabrutinib with very much lower frequency of grade 3 or higher. Infections, though, still paramount, including grade 3 or higher. So again, infections. And there seems to be a little bit more neutropenia with this agent for grade 3 or higher. So I think that's something to keep an eye on with zanubrutinib. But the other side effects, such as arthralgias, some of the dermatologic issues, bleeding, definitely lower frequencies and earlier on. So what about the head-to-head data? I think many of us, extrapolating from all the other trials where they were given without comparative data, obviously this is something we've been looking forward to for a long time. So at this meeting, having the Elevate relapse refractory and high-risk patients, acalabrutinib versus ibrutinib, which we'll go over some of that data. And then coming up shortly in the next few days at EHA, the comparative of zanubrutinib versus ibrutinib also in relapse refractory CLL patients will be presented. So for the Elevate data, which is ibrutinib versus acalabrutinib in high-risk relapse refractory CLL patients, and this definition was specifically for patients with deletion 17p or 11q deletion who had at least one prior line of treatment. They were randomized to either ibrutinib or acalabrutinib until progressive disease or unacceptable toxicity. And the primary endpoint here being PFS with secondary endpoints of overall survival and then the emergent adverse events and atrial fibrillation. So the presentation from the meeting here at ASCO, the major take-homes from the presentation was that acalabrutinib is non-inferior to ibrutinib, so the median PFS was the same in both arms. The adverse events that led to treatment discontinuation was less with acalabrutinib versus ibrutinib-treated patients, but what was statistically significant was the lower incidence of atrial fibrillation with acalabrutinib versus ibrutinib. And just to go over some of the cardiac adverse events regarding the acalabrutinib versus ibrutinib, again, any grade seems to be similar between the two drugs. In terms of atrial fibrillation, statistically significant different between acalabrutinib and ibrutinib. It also seems that the hypertension, any grade was less with acalabrutinib versus ibrutinib, and maybe that with longer follow-up, we'll see if that plays into the decrease in the atrial fibrillation rate or not over time. Infection rates seem similar between acalabrutinib and ibrutinib, grade 3 or higher, about 30%, and similar second primary malignancies, excluding non-melanoma, similar between the two drugs. The Alpine study that will be presented in a few days with zanubrutinib versus ibrutinib, again, this was in relapse refractory CLL patients. They've had to have one prior systemic therapy and were randomized to either drug. The primary endpoint here being overall response rate, with secondary endpoints being PFS, overall survival, and safety. And it's come out, so this is data that has come out, although again, we'll wait the final presentation at EHA. The overall response was higher with zanubrutinib versus ibrutinib, with the PFS by investigator-initiated assessment favoring zanubrutinib over ibrutinib. From an adverse event perspective, atrial fibrillation and flutter, similar to the acalabrutinib data that was presented here at ASCO, was significantly lower with zanubrutinib versus ibrutinib. So I think, obviously looking at the head-to-head data, clearly we're going to need longer follow-up on some of the other adverse events when comparing the head-to-head data. I think it's very young. But certainly the atrial fibrillation rate with acalabrutinib and zanubrutinib compared to ibrutinib seems to be less than ibrutinib, and I think that's something that's noteworthy. But whether the other adverse events will be significantly different over time, I think we'll need to wait that out. And certainly with the zanubrutinib data, whether the response and PFS will differentiate with longer follow-up, I think we need to follow as well. So let's go back to our patient. So here he has renal insufficiency with a creatinine of 2. He has factor V Leiden, a history of DVT on warfarin. He has a high white count, anemia and thrombocytopenia, and adenopathy as favorable prognostic markers. So when we talk about which options about BTK inhibitors, which we talked, both Carrie and Bill sort of discussed this case earlier, can we self-select a little bit? If you're going to choose a BTK option in this case, are we going to differentiate at all between the BTK inhibitors, given the data we just saw? And so I'm just going to talk a little bit about how to manage some of the safety issues that develop with the BTK inhibitors that I discussed previously. And so as Carrie noted, that typically we don't like given the exclusion of warfarin on a lot of the ibrutinib and acalabrutinib studies that were done earlier, we're not happy with combining. It's not to say that it never happens. As Carrie noted, sometimes you need to do what you have to do, depending upon what you're having to treat for your patient. But certainly we would prefer switching the anticoagulation from warfarin to another agent if possible. If a patient does develop atrial fibrillation that's new onset, trying to manage them through that, it doesn't mean that you absolutely have to discontinue the BTK inhibitor, but certainly sometimes that is done while the atrial fibrillation is being controlled. And then whether or not you need to switch to an alternative therapy, I think depends on how the patient is doing with the atrial fibrillation or not, and in a discussion with the patient about whether or not they want to be switched. But clearly we have data that patients have been able to maintain BTK inhibitor therapy with new onset AFib. And so certainly that's something that needs management and discussion with your patient, depending upon their other comorbidities and also obviously concerns. Typically, if they develop AFib, we'll consider beta blockade. And you have to watch, of course, drug-drug interactions when you're looking at other agents such as CYP3A4 inhibitors or the P-glycoprotein substrates such as amiodarone, which interact with the BTK inhibitors. So when you're managing the AFib, you might consider changing, you'll consider what agents to use along with the cardiologist. And we'll, where possible, avoid combination with vitamin K antagonists. And of course, with hypertension, absolutely, prior to starting a BTK, if your patient has hypertension, consider managing appropriately. And if they develop it while on a BTK inhibitor, of course, to do that as well. With bleeding, as I noted from the studies, major bleeding is not as common with any of the BTK inhibitors, thankfully. But certainly minor bleeding occurs all the time with petechiae and other minor bleeding reports and contusions and so on. So when you encounter bruising, it does not mean that you have to stop a BTK inhibitor. This does not confer an increased risk of major hemorrhage. If the patient is having a procedure, counsel the patient about how to hold the BTK inhibitors. I think patients need to be reminded about that because they don't necessarily know that they have to stop the agent. So it's always good in the educational process. And obviously, if they have minor bleeding, you can hold the therapy. Major bleeding, you might even need to transfuse patients appropriately, depending. And encourage the patients to really abstain from over-the-counter supplements that may also exacerbate bleeding risks, such as vitamin E or fish oil. With infection, we've noted that this can occur on any of the BTK inhibitors, including grade 3 infections, which are about 20%, but minor infections in higher frequency. And so certainly having your patients note to call for any signs or symptoms of infection and to work up appropriately. With diarrhea, it's very common to see some diarrhea in BTK inhibitor therapy, and most of this can be ameliorated with supportive care and anti-motility agents, or even switching the timing of the dosing of ibrutinib. Obviously, on the drugs like acala and zanubrutinib, they're twice-a-day drugs, so you can't try that. But certainly, you can supportive care is usually all that is necessary. Although some patients might have more severe diarrhea that needs to hold therapy or have dose reduction. And then fatigue, arthralgias, and myalgias are a little bit more challenging. And so, we tend to, for patients who have fatigue early on in the course of therapy, certainly that could be due to the disease itself. And so we'll sort of discourage dose reductions. But if it occurs later, we're thinking about whether or not this is due to other causes or due to therapy. And so certainly an evaluation of potential causes of fatigue is warranted in that setting before drug holiday or dose reductions. But certainly if everything's been excluded, that may have to occur. In terms of arthralgias and myalgias, that's more tricky and difficult to manage. Certainly there's been a lot of anecdotal data and some reports about supportive care data with that, but trickier, absolutely trickier. And so you can try different supportive care measures. Clearly, if they're early grade, most of those arthralgias, again, are early on and do go away. But there are some patients where they are absolutely plagued by the arthralgias, and it becomes difficult, and you do have to dose reduce or hold therapy, and that can become quite challenging. And there are some patients who actually develop this actually later, much later on as well. And so those are, hopefully maybe a better understanding of some of these mechanisms or how we can support our patients through this will be important in the future. And then similar when we focus on acalabrutinib, obviously the other side effects that we talked about, how to mitigate for some of those side effects with ibrutinib, absolutely apply to the second generations as well. Headaches, as I said, was more common with acalabrutinib. And so obviously these are typically when one first starts the drug and usually happen in the first month or two. Most of this is very readily managed with acetaminophen and some caffeine. And again, appropriately monitor for the other side effects that we talked about with ibrutinib. And then for zanubrutinib, I think with longer term follow-up in the clinical trial data that we have, as that accrues and does more, and we have longer adverse event follow-up with zanubrutinib, we'll see about the degree of neutropenia and infections that potentially could occur. You might need to utilize growth factor more appropriately with this agent, more commonly potentially than acalabrutinib or ibrutinib. And again, we're going to continue to monitor for the side effects that we know about with the class overall. So in summary, just to talk about the BTK safety before I hand it over to Carrie, obviously patient-specific comorbidities are going to be important when starting our patients and deciding between agent, whether BTKI or ven-based therapy. Patients with arrhythmias or poorly controlled hypertension may do better with other treatment modalities such as venetoclax-based therapy. As the data continue to emerge on BTK combination with other agents, obviously, there are opportunities, as Bill alluded to earlier, with ibrutinib and venetoclax, so fixed duration of treatment rather than indefinite therapy may reduce the potential for these longer-term adverse events that may not go away, such as hypertension and atrial fibrillation. And obviously, the follow-up of the head-to-head trials that were presented here at ASCO and upcoming at EHA, longer term follow-up of these will help us distinguish the toxicity profile if one BTK agent might be better than another, or are they more similar than we think they are in terms of some of these adverse events. Although it seems like the atrial fibrillation frequency for both acalabrutinib and zanubrutinib do appear to be less than ibrutinib, but whether some of these other toxicities we talked about are less, we'll see over time. And then clearly, given the impressive efficacy of the BTK class in general, we need to learn better how to manage some of these BTKI emergent toxicities so that we can obviously be able to take care of our patients better and so that they will not hopefully need to have dose reductions or interruptions of therapy, particularly if that winds up being detrimental to their overall efficacy and care in long term. And for some individuals, it may be less relevant because they have good risk disease and dose interruptions may not be as paramount long term. But for some of our higher risk patients, it might be more important to do so. So I think we just need better data and better ways to manage some of these toxicities. And with that, I will turn it over to Carrie, who's going to talk more about sequential use of BTK inhibitors in CLL.
Terrific. Thank you, Nicole. I'm very excited to open our last section, which is looking at sequencing with BTK inhibitors. I also have 2 cases to start that I would love my colleagues' input on. So this is a case of a 67-year-old woman who has CLL that was actually diagnosed in 2008. So she'd been on observation for some time and now requires treatment for progressive cytopenias and has a bone marrow biopsy showing extensive marrow infiltration with CLL. Her major comorbidity is hypothyroidism. And then in terms of her CLL disease characteristics, she is unmutated at 0%, has a normal karyotype, FISH panel showing deletion 13q, which is a good risk finding, and no TP53 mutation. So good risk cytogenetics, and then obviously the finding of an unmutated IGHV. She elected to start treatment with ibrutinib at the standard dose in CLL. However, after 8 days of treatment, she calls saying she's completely unable to get out of bed, even to use the bathroom, because of very severe joint inflammation, including her hands, her ankles, her legs, and even her knees. So she stopped taking ibrutinib and started taking low-dose prednisone, and within 24 hours was able to walk around and do her normal activities. And by a week, all the joint inflammation had resolved. So close to 2 weeks after stopping ibrutinib, she restarted it at a reduced dose, and within 24 hours, the same kind of joint inflammation recurred, and she called us right away and was like, hey, this is going to happen again, you know. So now the question is, you know, you have someone on a very good first-line treatment who is clearly unable to tolerate this with no improvement with dose reduction. So I'd love to get the input from my colleagues on this, and I was going to start with Nicole since she was talking about safety.
Yeah, so this will just feed that in, and this is the difficult one, right? So this is the more challenging. You know, we talk about atrial fibrillation and concern for all that stuff, but these are the more nagging side effects for the patient, and this is difficult because it's really early on, and so you're trying to hope to mitigate some of this. And could you know, keep her on it and dose reduce again? Certainly you could. You can re-challenge at the lower dose and have her on some steroids, certainly, to see if that happens. Obviously, if it recurs despite dose reduction and holding again and so on and so forth, then you're looking for an alternative option. I clearly would try to do a second generation if possible to see if that would recur or not, because obviously I think she's got good risk disease. I mean, certainly, can you switch altogether from BTK to another therapy? Of course you could, but you know, if you decided to do a BTK and could switch to a second generation, that's what I would do. That's what I would try to do.
Does Bill have any input additionally?
Sure. So I think a couple of things maybe to point out. One of which is we have 2 category 1 options for BTK inhibitors on the NCCN guidelines. So we probably should have a discussion. Maybe we can do that in the round table about which would be our first choice for initiating first-line treatment for patients. In this case, ibrutinib was chosen. Perhaps at the time that was the only category 1 option in the guidelines. And we do see arthralgias, myalgias associated. My experience has been that it's not a toxicity that goes away with dose reduction. Certainly, we don't want the patient on prednisone indefinitely, so that really isn't a reasonable option to continue ibrutinib therapy. So this would be a patient that I would definitely be considering switching to acalabrutinib. And I think the other point maybe I should make that also relates to Nicole's presentation, and that is these head-to-head comparisons focus on the adverse events of special interest, things like atrial fibrillation, bleeding events, etc. They also focus on grade 3 or greater toxicities. However, from a practical perspective and from somebody who sees a lot of CLL and starts treatment and manages patients on these agents every day, we can't ignore the less than grade 3 toxicities, particularly if we're talking about continuous and indefinite treatment. I don't think anybody would want to live with grade 2 diarrhea indefinitely. Or some of the other toxicities that we see. So while the objective data and the data we have for comparison purposes are these head-to-head trials, I think we do need to also have a conversation around the practical aspect and the less than grade 3 toxicities and what are our expectations and how we address those challenges on a practical daily perspective.
I think that's a great point. And also those head-to-head comparisons look at frequency of adverse events in groups of patients. But for an individual, one drug or the other might be more tolerable for that specific person. Yep. And so when you're thinking about what to do for a patient, that matters as well. Yep. I had a few discussion points just related to this, and I think we covered them all. But, you know, as Nicole said, many early side effects diminish into treatment, but some actually are intolerable, and something that is so severe that you can't get out of bed and recurs is clearly something that's not going to be tolerable for this person. And that dose reduction may not resolve this. Patients who develop very early side effects requiring discontinuation will go on to need new therapy in the short term, and a week of BTK inhibitor isn't going to put the CLL in remission, so you have to think about your next option. That being said, I think patients who develop late side effects, so maybe something like atrial fibrillation that's difficult to control related to a BTK inhibitor 3, 4, or more years into therapy, those patients, while we don't think the BTK inhibitor is in any way curative, can probably be observed for a time off therapy. So not all patients who discontinue a BTK inhibitor for toxicity actually have to switch to another active therapy right away. Related to this, sort of on the other side that we think about with sequencing, is a patient, Robert, who's 42, and this is a younger man with no significant comorbidities, and he has very high-risk CLL, unmutated complex karyotype, deletion 17p, so very high risk off the bat, and he started ibrutinib shortly after his diagnosis in 2017. And he tolerated this well, except for hypertension, which was controlled on lisinopril and brittle nails, but he was still working full-time and running half marathons, so this didn't really impact his life much. However, he now comes to follow up with an increasing lymphocyte count. His had gone down to 7 or 8 or less, and had now increased to 20 since his last 3-month follow-up. And then since he was seen at a center that has this available, got BTK mutation testing, was found to have a BTK C481S mutation, which is associated with therapy resistance and progression while taking ibrutinib. So the question now is, how do we proceed with this patient? And I have some points on the next slide, and I thought I would let Bill take this one first for how he would think about this patient.
Sure. So Robert scares me. I get nervous with Robert for the obvious reasons of having high-risk features, 17p deletion. He's young and he is failing first-line BTK inhibitor. So he has very high-risk disease. This is the type of patient that I hope, if they are being seen in the community, they would be referred to an academic center where we have clinical trials available for this patient. He probably has young children, and his life span and life expectancy probably is shortened by virtue of having this high-risk disease. So we need to do everything that we can to try to effectively manage his disease. He is somebody that in the back of my mind, I'm thinking about, does he have a sibling who is a potential donor? And anything that we give him will have a shorter expected duration of efficacy compared to what we see in general. For example, shorter progression-free survival with first-line BTK inhibitor-based therapy, shorter duration of activity with BCL2 inhibitor-based therapy, et cetera. So I would not, because he has a mutation in cysteine 481, I wouldn't be thinking about an alternative covalent inhibitor of BTK. We don't have any reversible inhibitors that are yet available commercially. Those are going to be potentially available at an academic center, so that would be a way to keep him in target by switching him to a potentially active reversible inhibitor of BTK and push back the timeline a bit before you switch targets potentially to BCL2 inhibitor. Commercially available option is a BCL2 inhibitor for him, which would be a venetoclax-based therapy, and in this case, I would follow the Murano trial and give him venetoclax plus rituximab for 2 years of, at least 2 years of venetoclax and 6 cycles of rituximab. Cellular therapy in the form of CAR T cell therapy, not yet commercially available, but also another reasonable option to consider. So he's somebody who deserves a lot of attention and a lot of thought, and also long-term planning.
That covered a lot, but I'll ask if Nicole has anything she wants to add to this.
No, I was obviously thinking the same thing. So obviously, yes, I agree. There are things on clinical trial, and Bill alluded to those, the non-covalent and CAR T cell. And then, of course, I'm concerned that the patient will obviously also need an allogeneic stem cell transplant. So absolutely.
So kind of the way I broke it down previously is just outlined on this slide here. So progression on a BTK inhibitor, really venetoclax is the currently approved agent with the most data behind it in terms of using after progression on a BTK inhibitor. PI3 kinase inhibitors are another available class of drugs which may work, but there's not really extensive testing of those in BTK inhibitor resistant patients. So they're not expected to be as effective as venetoclax, but we don't have the same kind of prospective wider scale data using a PI3 kinase inhibitor after a BTK inhibitor. But that is a commercially available option. And then clinical trials should definitely be considered in this patient population. And I'm going to show you some venetoclax data after BTK inhibitor that'll make it clear why that's the case. But these obviously include these reversible non-covalent BTK inhibitors we're all excited about. There's BTK degraders, there's novel mechanism action drugs like PKC beta inhibitors, and then of course cellular therapies. CAR T being investigational, and then allogeneic stem cell transplant, which of course you have to do when disease burden is low. So those are really considerations for resistant patients. And then the other category there is actually intolerance. And in this case, yes, all the same ideas and therapies available for resistant patients are still available for intolerant patients, but it's really a benefit for those patients if you can continue using the mechanism you already started for them and try to switch to a different agent, which may be tolerable for them, as some of the off-target effects, et cetera, are different. And I will point out too that while acalabrutinib is fully FDA approved for CLL, zanubrutinib is FDA approved for mantle cell lymphoma and can be prescribed off-label in CLL and is in the NCCN guidelines for patients who didn't tolerate a different BTK inhibitor. So that would be an option in this particular case of intolerance. So we've sort of covered some of this too earlier, but this is just some data looking at real-world discontinuation rates for BTK inhibitors. And as you'll notice, the most frequent reason for discontinuation is toxicity. And of course, the discontinuation rates in a real-world setting are much higher than in a clinical trial setting. But intolerance is actually a very important reason people stop taking BTK inhibitors. Towards that point, so the original first-in-class BTK inhibitor, ibrutinib, there's more people had taken that and become intolerant before the development of these kind of second-generation ones, acalabrutinib and zanubrutinib. So it's actually been prospectively tested what happens when you give acalabrutinib to people who didn't tolerate ibrutinib. So this is a phase 2 study that included 60 patients, and these are patients who discontinued ibrutinib for intolerance and not for disease progression. And there were strict criteria for what qualified as intolerance and what the adverse events were. It's always hard to capture all of that data, but they did actually have to meet this criteria for intolerance and then be observed till they developed progressive disease. So some need to continue treatment by virtue of disease progression, and then went on to take acalabrutinib. So this is testing acalabrutinib in people who didn't tolerate ibrutinib. This is the patient disposition for this study, and I think one of the most interesting things about this data is that the adverse events were not the number one reason for acalabrutinib discontinuation. It was actually disease progression. And remember, these are people who have taken ibrutinib for a while in some cases before starting acalabrutinib. But adverse events was actually the second most common reason for treatment discontinuation, with 7 of 60 or 12% of patients discontinuing for that, which might sound high, but when you consider 100% of these patients discontinued ibrutinib for intolerance, this really speaks to the fact that acalabrutinib can be tolerable after ibrutinib in patients who didn't tolerate ibrutinib. Here's the overall response data from this study. And you can see here that people do respond to acalabrutinib after discontinuing ibrutinib for intolerance. So discontinuation due to lack of tolerance in a responding patient really says that people will respond to a subsequent BTK inhibitor with the same mechanism. So I think this is pretty clear, and I would consider the overall response rate to be 78% because I consider partial remission with lymphocytosis to be a good response in CLL. Here's the progression-free survival and overall survival for that study. Just another way of demonstrating that acalabrutinib is effective in ibrutinib intolerant patients. Okay, so this is kind of interesting data. It's one of those things that's more difficult to put together sometimes, but this is looking at recurrence of the specific adverse event that led to ibrutinib intolerance in the same patients. And you can see here that for patients with specific intolerances, such as on the top atrial fibrillation, you can see of 16 patients, only 2 had that occur with acalabrutinib, and they were both a lower grade. And it just shows you numerically that for specific ibrutinib intolerant adverse events, fewer of them recurred on acalabrutinib, and a lot of those were lower grade if they did come back with a different BTK inhibitor. So here's a similar study with zanubrutinib. So this is again looking at either ibrutinib or acalabrutinib intolerant CLL patients. And if you look, it looks like there's more ibrutinib than acalabrutinib intolerant events that are captured here. But this is looking at which events recurred or did not recur. And you can see the majority of these adverse events did not recur. So it's just another way of looking at switching BTK inhibitors to a different covalent BTK inhibitor in patients who are intolerant but not resistant to this, to one of these agents. Here you can see the overall response rate, and you can see it's broken down by CLL, SLL, so the study included mantle cell as well. So this is just the CLL and SLL specific data, and I think this is pretty early data, so some of these patients that have stable disease might actually convert to a response later, so I wouldn't consider that to be inadequate in this particular setting. So that's looking at intolerance switching to a BTK inhibitor with the same mechanism of blocking BTK or inhibiting BTK. The other kind of exciting thing that is happening now is that there are reversible BTK inhibitors like pirtobrutinib, which is known as LOXO 305. So you can see the kinase map there for that. And the nice thing about this drug is because it does not bind at the C481 residue, it actually is effective in patients who have a C481S mutation in BTK. So this drug has been given to patients both with and without BTK mutations. And here you can see the response profile in a clinical trial with pirtobrutinib, which is known as LOXO 305. And the response profile looks similar to other BTK inhibitors. You can see the follow-up is relatively short, and it's showing you only greater than 10 months on the far side. But the number of people with response, which is shown in green as a partial remission or partial remission with lymphocytosis, is increasing over time. So responses are deepening as patients are on therapy to a very reasonable response rate. This is also some very interesting data with pirtobrutinib from that study, and this is something that I think everyone was very excited about. And the question is, will this new drug, which is investigational still, pirtobrutinib, have efficacy in patients who are resistant to our other really effective targeted therapies? So you can see here the overall response rate in all patients in the study that were accessible for response was 63%. But what's interesting is patients who had previously taken a BTK inhibitor, it's 62%. Who had at least taken a BCL2 inhibitor, it's 65%. And then patients who had taken both a BTK inhibitor, and again, those are the irreversible covalent BTK inhibitors they're talking about here, and taking a BCL2 inhibitor, so double refractory patients potentially, have a 64% overall response rate. So regardless of which prior therapies they've been exposed to, the response rates are very similar, and that's really exciting. And you can also see the differences by BTK status, either if it's C481 mutant or wild type, and you've got responders in both categories there. So it's just really exciting to see that this drug is successful in patients who have resistance to our other targeted therapies. Here is duration of response, and they have it shown both with CLL, SLL, and with mantle cell lymphoma there. I do think it's important to note that, this isn't a very long follow-up, and if you look at the risk table, there's not many patients that we have data for past, like maybe like 8-10 months. So I really think that one of the most important things is it's going to be continuing to follow patients taking pirtobrutinib to really get a better handle on the progression-free survival with this agent, particularly in those groups of patients that are resistant to our different classes of therapies. So this is extremely exciting as preliminary data, and I think longer follow-up will really tell us what the value of this drug is and how successful it is in the longer term controlling CLL. So I think a major question now is how to sequence between our two major classes of approved drugs, which are BTK inhibitors and venetoclax. And so I'm going to shift gears just a little bit to talk about sequencing of these classes of drugs. In order to understand how to sequence them, it's helpful to look at what the data is like taken in a relapse refractory setting without having been exposed to the other agent. So this is data from the phase 3 RESONATE study with a pretty long-term follow-up. And of course, the ofatumumab comparator arm is not very exciting here, but you can see that the median progression-free survival with ibrutinib is about 44 months, which is quite good in this very high-risk kind of adverse characteristic cohort. And then here's the phase 3 study that led to the approval of the MURANO regimen, which is venetoclax plus rituximab, with venetoclax given for around 2 years. And you can see here, there's enough follow-up now to show that the median progression-free survival is 53 months. I wouldn't directly compare these studies. They have slightly different populations, but you can kind of get an idea of how long you expect this fixed duration venetoclax regimen to work for compared to, like a single agent BTK inhibitor. These are both years, years out. The median progression-free survival is years out. So the question now is, what happens if you give a BTK inhibitor until progression and then give venetoclax? So this is a phase 2 study that enrolled patients who had previously taken ibrutinib. So this is patients who were exposed to ibrutinib and were mostly resistant to it, who then took venetoclax. The dosing in this study was a little different than the MURANO trial because this was given as a continuous monotherapy and not as a 2-year fixed duration regimen with rituximab. But you can still see here that the median progression-free survival is shorter, so it's right around 2 years, unlike in the MURANO study where you've got this out to 50-some months. And I will point out that in the MURANO study, very few patients have been exposed to BTK inhibitors. So this is showing you that if you use venetoclax after BTK inhibitor resistance, your progression-free survival is shorter. And I think that's expected anytime you're resistant to a class of drugs. I also want to point out that the median progression-free survival is around 2 years. So even though I think it's appropriate to use the MURANO regimen in patients who are resistant to a BTK inhibitor like ibrutinib or acalabrutinib, I don't promise my patients that they can stop at 2 years because I know the median progression-free survival is around 2 years. So I don't think it's fair to tell them that they'll absolutely get to do a fixed duration therapy for that duration. Okay, so the question now is, what about the reverse? What if you give venetoclax as a fixed duration, observe people, and then do a BTK inhibitor? What does that do for your BTK inhibitor efficacy? You can do BTK inhibitor and venetoclax. Can you do the other? And there's really much less data in this area. The prospective data really comes from follow-up of patients that got treatment after completing MURANO, and that's a very low number of patients. And then this data, which is from a cohort study, which is looking at giving BTK inhibitors in patients who discontinued or progressed on venetoclax. And it's broken down here into 2 groups of patients, patients who had never taken a BTK inhibitor before taking venetoclax and patients who have. And the patients who have never taken a BTK inhibitor before taking venetoclax, you can really see that the BTK inhibitors do work after venetoclax, and this is an appropriate strategy. In patients who have taken a BTK inhibitor before, it really depends whether or not they're resistant to it. So people who discontinued a BTK inhibitor for intolerance can benefit from it and expect it to work after venetoclax. However, if you've become resistant to a BTK inhibitor, which is that kind of gold line, you don't really expect that after venetoclax you can go back to a therapy that you were previously resistant to. So whether or not you're resistant to a BTK inhibitor predicts whether or not it will be effective after taking a venetoclax treatment. So just to summarize this, BTK intolerance does not exclude this class of drugs and can be managed by switching agents. So the patient in the first vignette who had intolerance to ibrutinib can successfully take acalabrutinib, potentially, not have the same recurrent severe arthralgias and continue to benefit from that mechanism without being exposed to a different class of agent. However, patients with resistance to our current irreversible covalent BTK inhibitors can't switch between those because they have the same mechanism. So resistance to a BTK inhibitor requires change to a drug with a different mechanism. Venetoclax, again, is the most proven standard of care approved agent here. However, the median progression-free survival is around 2 years, so I would suggest that that's inadequate, particularly for someone like our patient in the second vignette who is young and fit and has high-risk disease. So I think that it's very important to think about a longer-term strategy in patients with BTK inhibitor resistance, including potential for investigational therapies such as reversible BTK inhibitors like pirtobrutinib, cellular therapies, or drugs with a genuinely novel mechanism of action that might benefit them. And then just lastly, we've known for quite some time that venetoclax is effective after BTK inhibitors, but also that BTK inhibitors are effective after venetoclax in patients who are not resistant to them. So I think I'll just end there, and we're going to do some question and answer.
That was a great presentation, Carrie. Thank you very much. And also thank you, Nicole, for your very good review of the current data. And I think it's important to emphasize that we really have discussed broadly across all the available data and current data. And it's great to see a lot of new data coming in real time, and I think it does factor into how we manage our patients. We're getting a lot of questions in this session. However, we have limited time to go over those questions. I think we'll pick a couple that are probably the key questions to answer, one of which I think relates to choice of covalent inhibitors of BTK. Nicole, you talked a little bit about differences in terms of the side effect and toxicity profile, and also introduced the data on the head-to-head comparisons. Both acalabrutinib and ibrutinib are approved and are listed on the NCCN guidelines as Category 1 options in the frontline setting and in the relapse setting. So maybe we can start with you, Nicole, if you can sort of summarize how you approach selection of covalent inhibitor and what are the key elements to that for you?
Sure. I mean, obviously, I think the efficacy of both ibrutinib and acalabrutinib are great and equal, so I don't deem them differently due to efficacy. I think the head-to-head with zanubrutinib, I think we'll have to see whether or not there's a distinguishment there in terms of efficacy. But other than that, for the approved agents, typically I have moved more to using the second generation, so I tend to use more acalabrutinib because of the data that we have, which suggests, even though they may not be statistically significant, that the decrease of frequency of some of the adverse events. So I will tend to use more acalabrutinib now than I did ibrutinib. Although, obviously acalabrutinib is a twice-a-day drug, ibrutinib is a once-a-day drug. You also have to look at drug-drug interactions for both, and the PPIs become sometimes an issue as well. But I tend to favor using more of the second-generation BTK inhibitors in general for my patients.
Carrie, your thoughts?
Yeah, I agree with what Nicole said, and I think about it similarly. I don't see any difference in efficacy between ibrutinib and acalabrutinib, which are the approved choices right now. And I do think, similar to what Nicole said, the toxicity does matter here, and it seems that acalabrutinib has fewer adverse events. The kind of silly thing that sometimes comes up in my practice is doctors don't usually think it's a big deal to take a drug twice a day, but there are a few patients that really think this is a big deal. And I have some patients where I'd be lucky if I could just get them to take a drug once a day. So the daily dosing for a few people is a huge deal. The combination with PPIs that you can do with ibrutinib, but not acalabrutinib for some people is a big deal. And then ibrutinib's been on the market longer, so sometimes if there's like someone that also sees a general oncologist that's very comfortable with that agent, and managing it, I do think comfort level with what you're prescribing, if you've been using one or the patients are wanting something that's more established, I think that matters too.
And I would agree with you all, and I think we're going to probably soon have a third Category 1 option on the guidelines with zanubrutinib. I do think that tolerability factors into efficacy, although we're not seeing that yet. Perhaps in the head-to-head comparisons, perhaps because of the duration of follow-up that we have on that available data. But I do think tolerability and ability to stay on treatment, on target, is an important feature, and that does drive also my selection of my first selection for a reversible and irreversible inhibitor of BTK, that being acalabrutinib with the second generation, because my experience has been that patients are able, if I'm thinking about monotherapy and continuous treatment, patients are able to tolerate it a bit better and stay on treatment longer with that agent, with all the other features that have already been discussed. I think maybe the other question that we'll finish up on is a question about, we're talking a lot about these combination therapies, combination targeted therapies, and fixed duration treatment. And one of the questions is, well, if you give a patient a combination targeted therapy in the first line setting, what do you do subsequently when they relapse? So maybe we can start with Carrie, and what are your thoughts, and what do you think are the important features when thinking about that question?
Yeah, I think the relevant combination here is BTK inhibitors and venetoclax together for a fixed duration, rather than like the venetoclax anti-CD20 combination. So far, those combinations are entirely investigational, so this will be an emerging question if one of those combinations is approved. However, having treated people in clinical trials with combination venetoclax BTK inhibitor, this question is more pressing for my clinic population than kind of for patients that have only received standard therapy so far. I think the major thing to consider here is that using a combination of a BTK inhibitor and venetoclax together for a fixed duration doesn't really mean resistance to these drugs. So if you give a combination until people are resistant to them, yes, it's unclear, you'd have to, do something else later. But if you just give them for a fixed duration and quit while you're ahead, which is how I describe it to patients, and you're not resistant to it, I think that either class of drugs could be used individually later. So you could give someone a BTK inhibitor monotherapy or a venetoclax anti-CD20 combination down the line when they relapse. I don't think it's excluded those classes of drugs. You might even be able to treat them with a combination again. But I think that giving a fixed duration combination therapy doesn't exclude those drugs from use again in the future.
Great presentations and great discussion. Thank you, Nicole, and thank you, Carrie, for your very, very great presentations and your insightful and informed discussion and responses to the questions.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/SYN860. This activity is supported by an independent educational grant from AstraZeneca.